Starting from question number 18. Okay, a 46-year-old man comes to the office with chest pain and dyspnea and exertion. He has no he has no known medical problems and leads a sedentary lifestyle. He is a lifetime non-smoker. Non-invasive cardiac testing is non-diagnostic. Left and right heart catheterization is planned. During the procedure, the catheter records periodic pressure changes with a maximum of 25 mm of Hg and minimum of 2 mm of Hg. The catheter is advanced further and then shows periodic pressure changes with a maximum of 25 mm of Hg and a minimum of 10 mm of Hg. Assuming the results of the procedure are normal, the first set of readings was most likely obtained from which of the following locations: left atria, left ventricle, pulmonary artery, right atrium, right ventricle. Pause 8 and give the answer. Okay, the correct answer for this is right ventricle, because they are asking about the pressure changes between 25 and 2 and minimum of 2 mm of Hg. So that pressure is in right ventricle. Why not left atrium? Because the pressure change over there is 6 among between the 6 and 12. Okay. Why not option B? Because the normal systolic BP um, in case of left ventricle is between 90 to 140 mm of Hg, while diastolic BP is 6 to 12 mm of Hg. Why not pulmonary artery? The difference where there is 10 to 25 mm of Hg. If they were asking about the second point, then that would be pulmonary artery. Why not right atrium? Because the pressure difference over there is 1 to 16 mm of 1 to 6 mm of Hg, and this is also in case of superior vena cava, because the pressure between right atrium and superior vena cava is the same. Okay, so let us see to this thing once again. Between right atrium and superior vena cava, the pressure difference is 1 to 6. Right ventricle 2 to 25. Pulmonary artery 10 to 25, right? And pulmonary artery which pressure, that is 8 to 13. Round about that. Okay. So cardiac catheterization is performed to evaluate for cardiac etiologies and obtain direct measurements of intracardiac pressures in patients with unexplained symptoms. In general, right-sided pressures are much lower than those of the left-sided, as the right ventricle is pumping blood into a much lower resistance pulmonary vasculature. A balloon-tipped pulmonary artery catheter attached distally to a pressure transducer is inserted into the subclavian or internal jugular vein. When the pulmonary arterial catheter enters the superior vena cava, a venous waveform appears. The balloon is inflated with air and the catheter is advanced. The location of the catheter tip is determined by the pressure readings as follows. The venous pressure waveform of the superior vena cava pair is a small amplitude oscillation. The pressure remains unchanged as the catheter is advanced into the right atrium. Normal pressure in the superior vena cava and right atrium is 1 to 6 mmHg, as I talked about this thing. As the catheter is advanced across the tricuspid wall into the right ventricle, a pulsatile waveform appears. The peak systolic pressure is the strength of right ventricular contraction, and the lowest, that is diastolic pressure, is just below the right atrial pressure. Right ventricular systolic pressure is normally 15 to 30 mm of mercury. Main pulmonary artery, sudden increase in diastolic pressure with no change in systolic pressure. This rise in diastolic pressure is due to pulmonary capillary resistance and backward transmission of left atrial pressure. The pulmonary artery diastolic pressure is normally 6 to 12 mm of Hg, but here they have taken round about 10. Okay, the diastolic pressure, but the systolic pressure they have taken is 25. Okay, catheter is advanced into the distal pulmonary artery branches. Pulmonary artery occlusion pressure or pulmonary capillary wedge pressure, that is called. Venous pressure in the left atria or left heart, left atrial pressure and left ventricular diastolic pressure. Pulmonary capillary wedge pressure is usually equal to pulmonary arterial diastolic pressure, which is 6 to 12 mm of mercury. Left-sided pressures are much higher than right heart pressures in order to maintain systemic perfusion. The normal left ventricular systolic pressure is approximately 90 to 140 mmHg. We talked about this, with the left ventricular end diastolic pressure of 6 to 12 mmHg. We talked about this. Right-sided pressure in the heart are lower than left-sided pressures due to lower resistance in the pulmonary vasculature. Right ventricular diastolic pressure is similar to right atrial and central venous pressure, which is 1 to 6 mmHg. Whereas pulmonary artery diastolic pressure is slightly higher, that is 6 to 12 mmHg, due to resistance to flow in the pulmonary circulation. Okay, so this is a pulmonary artery catheter, which is having a balloon and a balloon port with syringe. Okay, then we have right atrial proximal portion, that is uh, right atrial port. Then we have pulmonary artery, that is distal port, and with that we have thermistor port. Okay, so we talked about this. Right atrium mean is 1 to 6, right ventricle systolic is uh, 15 to 30, which is taken is round about like 25. Diastolic, which is taken is 1 to 6, but they have taken is 2 mmHg. Okay, pulmonary artery, that is 15 to 30, then 6 to 12, so that would be 10. Left atrial pulmonary capillary wedge pressure, left ventricular end diastolic pressure, the mean is taken is 6 to 12 mmHg. Okay, now next question. 18-year-old man suddenly collapses during a high school soccer game. There was no preceding collision or trauma. Immediate resuscitation is initiated, but he dies before the emergency medical service arrives. The patient had recently experienced occasional exertion related chest discomfort and dyspnea. Otherwise, he had no significant medical history. He, take, he took no medications and didn't use tobacco, alcohol, or illicit drugs. Which of the following is most likely to be seen on autopsy? Atherosclerotic plaque, atherosclerotic narrowing of the left anterior descending artery, dilation of all chambers within ventricular walls, extracellular deposits, and stiff ventricular walls, myocardial hypertrophy with patchy interstitial fibrosis, thrombus at the bifurcation of the main pulmonary artery. Pause it and give the answer. So the correct answer for this question is D. Why? Let us see to the explanation. Because myocardial hypertrophy with patchy interstitial fibrosis, that is seen with hypertrophic cardiomyopathy, which would lead to arrhythmia, which would lead to sudden cardiac death. Okay, why not the other options? Option E, that is atherosclerotic narrowing of the left anterior descending artery, that would occur in older adults, right? But in this case, it is a young man. Okay, that should be greater than 35 years. Okay, why not option B, dilation of all cardiac chambers within ventricular walls? Because this is associated with dilated cardiomyopathy, present with symptoms of heart failure like lower extremity swelling, dyspnea, and orthopnea. Why not option C, extracellular deposits and stiff ventricular walls? This is associated with restrictive cardiomyopathy due to amyloidosis and hemochromatosis. Okay, why not option E, thrombus at the bifurcation of main pulmonary artery, saddle pulmonary embolism, right? That is associated with fatal pulmonary embolism, potential cause of sudden cardiac, but would not associated with exertional related dyspnea and chest pain. Okay, let us see to the explanation. Sudden cardiac death is most often precipitated by cardiac arrhythmia, for example, ventricular tachycardia and fibrillation, markedly decreased cardiac output, impaired coronary artery perfusion. In older adults, age equal or greater than 35, myocardial ischemia due to atherosclerotic coronary artery disease, most common cause of death. Young adults who experience sudden cardiac death, hypertrophic cardiomyopathy, one of the most common precipitating disease. Most patients with hypertrophic cardiomyopathy are asymptomatic, exertional dyspnea, fatigue, chest pain, or syncope. Okay, they will present with that. Hypertrophic cardiomyopathy is an autosomal dominant genetic disorder, mutation of one of the several genes coding for cardiac sarcomere cardiomyocyte hypertrophy, predominantly affecting the septum and myofiber disarray, consisting of irregular arrangement of abnormally shaped cardiomyocytes, increased interstitial fibrosis. This structural disarray leads to conduction abnormalities that predispose to ventricular arrhythmias and sudden cardiac death. Why not option B? We talked about this. Dilated cardiomyopathy, least common cause of sudden cardiac death in hypertrophic cardiomyopathy in young adults. Symptoms of heart failure, for example, lower extremity swelling, dyspnea, or orthopnea, would not be capable of participating in strenuous activities such as soccer. In why not C? Extracellular deposits, stiff ventricular walls, restrictive cardiomyopathy due to amyloidosis or hemochromatosis. Although restrictive cardiomyopathy can cause sudden cardiac death, usually a preceding course of progressive and symptomatic heart failure. Thrombus, a bifurcation of main pulmonary artery, that is saddle pulmonary embolism, potential cause of sudden cardiac death. Preceding history of exertion related dyspnea and chest discomfort would not be expected. Okay. So, what is the educational objective? Hypertrophic cardiomyopathy, common cause of sudden cardiac death in young adults. Cardiomyocyte hypertrophy and myofiber disarray with increased interstitial fibrosis. Disarray creates a substrate for ventricular arrhythmia, ventricular tachycardia, ventricular fibrillation, lead to sudden cardiac death. Right. So this is a slide for hypertrophic cardiomyopathy. So we have interstitial fibrosis over there. It is represented with blue. That would be seen with trichome stain, right? And would have organized myocytes, right? Okay. Okay. The next question. A 55-year-old man comes to the office for follow-up of hypertension and coronary heart disease. He has been on several medications in the past with suboptimal blood pressure control. The physician considers adding verapamil to the patient's current regimen, as its vasodilatory properties make it useful for controlling systemic hypertension. Verapamil also affects cardiac contractility but has minimal effect on skeletal muscle. Which of the following properties of skeletal muscle is responsible for its resistance to the medication? Option A, calmodulin independent excitation, contraction coupling. Option B, decreased troponin affinity to intracellular calcium. Option C, elaborate T tubular system. Option D, lack of internal automaticity. Option E, little dependence on extracellular calcium influx. Pause it and give the answer. So the correct answer for this question is option E, little dependence on extracellular calcium influx. Why? Verapamil acts on L channel, not on extracellular calcium, right? Which are coupled mechanically with RYR channels of the smooth endoplasmic reticulum, right? So why not option A? Calmodulin independent excitation, contraction coupling. Here, that would be not calmodulin, right? Here it would be troponin, but not calmodulin is responsible for contraction of cardiac and skeletal muscle because calmodulin that is associated with smooth muscle cells. Okay, so cardiac muscle cells depend on extracellular calcium, not skeletal muscle cells, right? So that is associated with uh, cardiac muscle cells, right? Which are which are dependent on extracellular calcium, but not skeletal muscle cells. Okay, why not option B? Calcium channel blocker do not affect troponins affinity to intracellular calcium. Why not option E? T tubular system, because that would facilitate rapid release of intracellular calcium stores. Communication of extracellular space allows depolarization impulse to reach deep into the cells found in close proximity to smooth endoplasmic reticulum. Why not option D? Mechanical coupling between L-type and RYR calcium channel is responsible for skeletal muscle resistance to verapamil. Automaticity is found in cardiac, GI tree, and ureter. Okay, so we talked about this effect of verapamil on skeletal muscle cell. That is mechanical coupling, right? So we have normal state, that is L-type calcium channel, and verapamil blockage, right? Okay, so we talked about this. This is mechanical communication, and the inside of the cell we have RYR type 1 calcium channel. Okay, then we have sarcoplasmic reticulum, right? The RYR type 1 calcium channel that is found in sarcoplasmic reticulum, right? Okay, then we have intracellular environment, but these two uh, receptors, that is L type calcium channel receptors, are pods or channels. They are communicated with RYR type 1 calcium channel of smooth endoplasmic reticulum. Okay, so calcium plays an important role in excitation contraction coupling in cardiac, smooth, and skeletal muscle cells. Myocyte depolarization causes activation of L-type calcium channels on the plasma membrane. In cardiac and smooth muscle cells, influx of extracellular calcium activates sarcoplasmic reticulum RYR channels, inducing the release of additional calcium from the sarcoplasmic reticulum. That is calcium-induced calcium release. Released calcium binds to troponin, cardiac muscle, or calmodulin in smooth muscle cells, allowing actin and myosin to interact and cause muscle contraction. In contrast, the L-type calcium channel in skeletal muscles directly interact with RYR calcium channels, release calcium from the sarcoplasmic reticulum. This mechanical coupling between the receptor allow, allows sarcoplasmic calcium release to occur without significant influx of calcium across the plasma membrane. Verapamil is a NDHPs, that is non-dihydropyridine calcium channel blocker, that acts by blocking L-type calcium channel, preventing the initial calcium influx into the cardiac myocytes and vascular smooth muscle cells. Because skeletal muscle is not dependent on extracellular calcium influx, calcium channel blockers do not affect the skeletal muscle contractility. Why not option A? Because troponin but not calmodulin, contraction of both cardiac and skeletal muscle. Unlike skeletal muscle, cardiac muscle is affected by verapamil because due to its dependence on extracellular calcium, induced calcium release from the sarcoplasmic reticulum. Why not option B? Rise in intracellular calcium concentration. Structural change in the troponin complex allows actin and myosin interact and cause skeletal muscle contraction. Calcium channel blockers do not affect troponin's affinity to intracellular calcium. Why not option C? Elaborate T tubular system, skeletal and cardiac muscle, not in smooth muscle. Communication of the extracellular space allows the depolarization impulse to reach deep into the cell, nearer to the myofilaments. Close proximity to the sarcoplasmic reticulum facilitate rapid release of intracellular calcium stores. Wiener option D. Unlike cardiac myocytes, specialized smooth muscle tissue, for example gastrointestinal tract, ureters, does not display automaticity. They are talking about skeletal muscle. It doesn't display automaticity and contracts only in response to neurotransmitter acetylcholine. However, the mechanical coupling between L-type and RYR calcium channel is responsible for skeletal muscles' resistance to verapamil. So, contraction initiation in cardiac and smooth muscle cells is dependent on extracellular calcium influx through L-type calcium channels, which can be prevented by calcium channel blockers, verapamil. Skeletal muscle is resistant to calcium channel blockers as calcium release by the sarcoplasmic reticulum is triggered by a mechanical interaction between L-type and RYR calcium channels. Okay, so we have talked about this thing. In case of now they're talking about effect of verapamil on cardiac muscle cell calcium induced release, right? So we have normal state L-type calcium channel on plasma membrane. Then we have RYR type 2 calcium channel. There were RYR type 1 calcium channel, but here it is RYR type 2 calcium channel. But there was a mechanical coupling, but over here there is no mechanical relation. Okay, so now effect of verapamil on smooth muscle cell through luminal calcium. We have SARCA on the smooth endoplasmic reticulum and L-type calcium channel on extracellular plasma membrane. Okay, and again we have RYR type 2 calcium channel. Okay, now question number 21. A 54-year-old man comes to the emergency department due to worsening shortness of breath for the last 3 days. His symptoms initially occurred with the exertion but are now present at rest. The patient couldn't sleep last night because of suffocating cough each time he tried to lie down. He considers himself generally healthy and states, I okay, I have never had to see a doctor for any problems. Family history is remarkable for asthma and hypertension. BP is 162 by 86 mm of mercury. Pulse is 92 per minute. Respirations are 26 per minute. An X-ray of the chest is shown in the exhibit. Which of the following is most likely diagnosis? Option A. Let me show the chest X-ray. Okay, this one. Acute decompensated heart failure, acute respiratory distress syndrome, idiopathic pulmonary fibrosis, obstructive pulmonary disease, pulmonary arterial hypertension, tension, pneumothorax. Pause it and give the answer. So, the correct answer for this question is acute decompensated heart failure. Why? Because we are in this case in this X-ray we can see facial sign, and with that there is pitchy bilateral opacification, right? And that would show pulmonary edema, right, due to transudate in the pulmonary interstitial and alveolar spaces. With that is shown cardiomegaly, right? Over here we can see this patchy infiltration. We will talk about this, and with that also we have cardiomegaly, right? We will talk about all those things. Okay, so why not option B, acute respiratory distress syndrome? Because ARDS and non-cardiogenic pulmonary edema, that would lead to endothelial injury plus pulmonary capillary leakage that is associated with sepsis, pneumonia and trauma. Chest X-ray is similar to acute decompensated heart failure, but pleural effusions are less prominent in ARDS. Why not option C, idiopathic pulmonary fibrosis? Because that would cause diffuse reticular opacities that is associated with decreased lung volumes. that would present with slowly progressive dyspnea and non-productive cough. Why not option D? Obstructive pulmonary disease that would present it with hyperinflated lungs with flattened diaphragm. For example, in case of asthma, asthma is exception is just X-ray may be normal during acute exacerbations, right? They're talking about chronic obstructive pulmonary disease. Okay, why not option E? Pulmonary arterial hypertension. In that case, what would be happen? Enlargement of pulmonary arteries in right ventricle, and there would be absence of pulmonary edema. In case of tension pneumothorax, white visceral pleural lines with absence of peripheral pulmonary markings, mediastinum shifted away from the affected site. This is important. Okay, so they have mentioned this. In case of decompensated heart failure, we have these facial lines, right? Let me show this. Like in this, they have mentioned just like that, these lines, right? Okay. Then there is haziness that is called patchy bilateral opacification, and there is costophrenic angle blunting, right? Okay, that is because of pleural effusion. Transudate in the pulmonary interstitial and alveolar spaces. Okay, let us see to the explanation. This patient has progressive dyspnea and orthopnea, cough when lying down, prominent pulmonary vessels, patchy bilateral airspace opacities, blunting of the costophrenic angles, pleural effusions, facial sign, created by fluid trapped between the right upper and middle lobe, acute decompensated heart failure, chronic hypertension, common cause of heart failure, concentric left ventricular hypertrophy, resulting diastolic dysfunction. In acute decompensated heart failure, increased atrial and ventricular filling pressures transmitted to the pulmonary vasculature, fluid transudation into pulmonary interstitial and alveolar spaces, cardiogenic pulmonary edema. Then we have curly B lines, which are short horizontal lines perpendicular to the pleural surface, represent edema of the interlobular septa. Cardiomegaly, cardiac to thoracic width ratio is greater than 50%, also common in heart failure, but it is difficult to assess on anteroposterior view due to magnification of the heart. Why not option B, acute respiratory distress syndrome or non-cardiogenic pulmonary edema? That would result from endothelial injury, pulmonary capillary fluid leakage, sepsis, pneumonia, or trauma. Chest X-ray is I talked about this, similar to acute decompensated heart failure, but pleural effusions are typically less prominent with ARDS. Mostly alveolar opacification is seen. Okay, why not idiopathic interstitial fibrosis? Because that would present with diffuse reticular opacities, decreased lung volumes. With that, slowly progressive dyspnea and non-productive cough, right? Okay, why not option D, chronic obstructive pulmonary disease? That would present with hyperinflated lungs and flattened diaphragm, right? As I talked about this, asthma is an exception. Is the chest X-ray typically normal between exacerbations? Okay, why not option E, pulmonary arterial hypertension? Enlargement of the pulmonary arteries, right ventricle, absence of pulmonary edema. Why not pneumothorax? Because that would present with white visceral pleural line with an absence of peripheral pulmonary markings. This thing is important. The mediastinum is often shifted away from the affected side in tension pneumothorax. This is important. So this is congestive heart failure. We would see facial sign, right? With that we would also see curly B lines, right? Okay. Then the normal cardiac salute and that is compared with enlarged cardiac salute. The cardiothoracic ratio is greater than 50. So heart width to thoracic diameter, cardiothoracic ratio is greater than 0.5. Okay. Okay. Then this is with acute respiratory distress syndrome, diffuse coalescent opacification. Okay, okay, we talked about this thing. Okay, interstitial lung disease. Here it would present with diffuse coarse reticular opacification, right? That is reticular opacification. In case of COPD, there is narrowed cardiac cell and with that flattened diaphragm. So there would be lung inflation in COPD, right? Pulmonary arterial hypertension. In that case, there would be enlarged hyla because of pulmonary arteries, right? In case of pneumothorax, what will happen? You can see this thing. Okay, I just removed this thing, you know, just like this one, right? Okay, so there is air, and with that there is collapsed lung, right? Over here, this one is collapsed lung, but over here outside this thing, this is air. Okay, okay, next question. A 71-year-old man comes to the emergency department due to sudden onset vision loss in his left eye for 1 hour. He has a history of coronary artery disease, hypertension, and type 2 diabetes mellitus. BP is 145 by 80 mm of mercury. Pulse is 72 per minute. On examination, the patient can see only hand motions to the left eye. Fundoscopic examination of the eye shows cherry red spot in the macula with surrounding retinal whitening. Cranial nerve examination is otherwise unremarkable. There is left-sided neck brood. On cardiovascular examination, which of the following is most likely path of the embolus causing this patient symptoms? Option A, external carotid artery, facial artery, ophthalmic artery, retinal artery. Option B, external carotid artery, ophthalmic artery, retinal artery. Option C, external carotid artery, temporal artery, then retinal artery. Option D, internal carotid artery, interior cerebral artery, then retinal artery. Option E, internal carotid artery, ophthalmic artery, and retinal artery. Pause it and give the answer. So the correct answer for this is option E. Why? Because in case of internal carotid artery, ophthalmic artery, and retinal artery, right? In this case, the patient is presented with acute painless monoocular lesion. What will happen in this case? What is happened? A retinal artery is, we know that it travels within optic nerve, right? A retinal artery would travel within optic nerve that is supplying inner retina plus optic nerve surface, right? So that is associated with the retina. Okay, why not option A, external carotid artery, facial artery, right? A lot of anastomosis, but neither supply the retina. These things are not supplying the retina. Talking about external carotid artery and facial artery. Why not option B, external carotid artery, ophthalmic artery, retinal artery? Ophthalmic artery receives blood supply from internal carotid artery, not external carotid artery. This is clear. Okay, why not option C, external carotid artery, temporal artery? A lot of anastomosis, but neither supply the retina. Again, external carotid artery and temporal artery neither supply the retina. Okay, why not option D, anterior cerebral artery? So anterior cerebral artery is the branch of circle of Willis. If occlusion occur, there would be loss of strength and sensation in the contralateral lower extremities. There would be incontinence and transcortical aphasia. Okay, so we have like internal carotid artery that is giving uh, okay, let's say if we have internal carotid disease, a thrombus, okay, then we have, let's say, internal carotid artery that is giving branch to ophthalmic artery, right? That would give um, Okay, that would give branch to central retinal artery. So the clot is moving through the internal carotid artery, then to the ophthalmic artery, then to the central retinal artery. So that would lead to blindness. Okay, so we have also supra, that is that retinal artery is going inside the optic nerve. This is important. Then we have supraorbital artery. Okay, so retinal artery occlusion, that would lead to acute painless monocular, this is important, right? So monocular vision loss. Thromboembolic complications of atherosclerosis in the internal carotid are the most common cause of retinal artery occlusion. Ophthalmic artery receives its supply from the internal carotid artery, so that is the reason for option. Retinal artery travels within the retinal nerve, right? Supply to the inner retina plus surface of the optic nerve. We talked about this. Why not option A and C, right? External carotid artery and those. So there are a number of anastomosis between branches of ophthalmic artery and branches of the external carotid, including the facial and temporal artery. But neither branch anastomose with the retinal artery or supplies the retina. Why not option D? Anterior cerebral artery is the branch of the circle of Vallis that would supply blood to the midline portion of the frontal and superior medial parietal lobes, that could lead to loss of strength and sensation in the contralateral lower extremity. We talked about this thing, incontinence and transcortical motor aphasia. So retinal artery occlusion, acute painless monocular vision loss, thromboembolic complications of atherosclerosis traveling from the internal carotid artery and through the ophthalmic artery, right? This thing is important. This is called circle of Willis. Okay, so we have, let's say, middle cerebral artery, right? Um uh, that would come from internal carotid artery, right? Internal carotid artery that would give branch to the middle cerebral artery, right? Okay, then we have uh, okay, then we have anterior cerebral artery, right? Okay, then we have interior communicating artery. First, remember these things. We have internal carotid artery that would lead to middle cerebral artery that is connected to the anterior cerebral artery, right? Sorry, yeah, that is connected to anterior cerebral artery. They are communicating with each other. I mean to say, anterior cerebral artery are communicating with each other through anterior communicating artery, right? Okay. Then, if we look to the posterior, like, so we have posterior communicating artery, right? And we have posterior cerebral artery. So middle cerebral artery, that is connected to posterior cerebral artery through posterior communicating artery, but there is no such case in case of anterior cerebral artery in middle cerebral artery, right? They are directly connected to each other. Okay. Then we have, if we look to the base, we have vertebral artery, right? That is uh, converted into basilar artery, right? And the basilar artery is giving many branches, like um, we can say anterior inferior cerebellar artery, right? And with that we have labyrinthine artery that is supplying internal acoustic meatus. Okay, so internal acoustic artery, okay, labyrinthine artery. Then also having pontine artery, and with that giving branches to superior cerebellar artery, right? So the branches of basilar arteries are anterior inferior cerebellar artery, labyrinthine, that is internal acoustic artery, pontine artery, and superior cerebellar artery. Okay, then the branches of middle cerebral, okay, middle cerebral artery, that is anterior choroidal artery, right? Okay, and with that anterolateral central uh, artery, that is lenticulo striate arteries. Okay, then uh, if you notice this thing, the internal carotid artery is also giving branch to ophthalmic artery. So they give us this idea that the ophthalmic artery is the branch of internal carotid artery. Okay, if we look to the anterior cerebral artery, that is giving branches to the intermedial central, that is perforating arteries, right? And with that, it is also giving rise to medial striate artery, that is recurrent artery of the Hubner. Okay, so once again, vertebral artery, basilar artery branches in interior inferior cerebellar artery, labyrinthine, that is internal acoustic artery, pontine artery, superior cerebellar artery. Okay, then we have posterior cerebral artery, that is communicating with middle cerebral artery through posterior communicating artery, right? Then we have uh, like uh, um internal carotid artery, that is giving branch to middle cerebral artery, right? With that also giving rise to ophthalmic artery. The middle cerebral artery is giving rise to interior choroidal artery, with that anterolateral central, that is lenticulostriate arteries, right? So I mean to say, the middle cerebral artery is giving rise to anterolateral central artery, but the interior cerebral artery, that is giving rise to intermedial central arteries, which are perforating. So interior cerebral artery is giving rise to perforating, while middle cerebral artery is giving rise to lenticulostriate arteries. Okay, so interior cerebral artery is communicating with each other through interior communicating artery. The interior cerebral artery is also giving rise to medial striate artery, that is recurrent artery of Hebner, right? I think it is enough for today. We will continue from the question number 23. Okay, thank you.